Go ahead, Carol.
Hi, everyone. Welcome to the afternoon session. I'm Carol Allen, and I am a member of the Symposium Planning Committee, as well as the ALS Advisory Council. I'm very excited to share with you today our next speaker. It's Brenda Schroeder. She graduated from Salisbury State University in Maryland with a bachelor's degree in nursing in 1991. She spent her first 4 years serving as an RN in the Navy Nurse Corporation stationed in San Diego, California. Sorry, my voice is suddenly going out. Brenda has vast medical experiences, having worked in labor and delivery, NICU, the operating room, medical surgical nursing, and 9 years in diagnostic imaging at Midcoast Hospital, where she became a certified radiological nurse. Her last 3 years have been spent at Midcoast Neurology and has been a key part of the Midcoast Maine ALS clinic for 1.5 years. So please welcome Brenda Schroeder with Symptom Management.
Thank you for the introduction. I am very happy and honored to be here today with you and talk about symptom management in ALS. And many of you may be already experiencing some of the symptoms you will hear mentioned today. So as I go along, if you have any suggestions that you would like to share with everyone on how you manage your own symptoms at home, please type them on the chat board for everyone else to see. Because as you know, the best suggestions come from those who are living with the disease. Recognizing symptoms and the management of these symptoms is a very important aspect of a person's function, well-being, and quality of life. Most all symptoms of ALS can be found in each individual depending on how far along they are in the disease process and also how ALS presents. Symptoms may start as weakness in the legs, and this particular person is initially adjusting to mobility issues versus a bulbar presentation where the head and neck are initially affected, experiencing salivia or drooling and problems with speech. The rate of how these symptoms will develop is unpredictable, as some people will be slow and steady, while others will be much quicker. So keep in mind that what may have worked several months ago to manage a symptom may not be working today. And what may work for one person may not work for somebody else. And as the disease progresses, most all individuals will experience similar symptoms. For the first symptom I would like to talk about is saliva management, or salivia. And what that is excessive saliva. It's not excessive saliva, there's no extra saliva made, it's just the inability to swallow the saliva that is in your mouth. It can be one of the most frustrating symptoms in ALS to manage and can significantly affect quality of life. People with the drooling can find it to be a nuisance, can produce some anxiety and some social embarrassment. And as I had mentioned a minute ago, why is it happening? And it's not from the body making extra saliva, it's just the inability to swallow that saliva. When someone swallows, there's a group of nerves and muscles in the face and mouth, pharyngeal area that all work together to move the food and fluids from the mouth down into the stomach, all while breathing. And in ALS, the ability to coordinate the chewing, the swallowing, the breathing become more difficult as the disease progresses. Because with ALS, these muscles will atrophy or become smaller and weaker, and the tongue can become spastic, leading to the difficulty or the inability to swallow. And this is called dysphagia. Dysphagia can create a lot of anxiety since it frequently causes choking, especially at meal times when saliva secretion is increased and the chance of aspiration or breathing in that saliva or food is the greatest. And this can be a really scary moment for everyone, especially if the person is having trouble clearing their airway because they do not have a good cough reflex. So how do we manage it? Well, there are several options available and are mainly trial and error, as they will not work for each individual. But early in the course of the disease, the extra saliva can be controlled by simply just being aware Other problem in just making a conscious effort to swallow the saliva. Some people carry tissues or rag, paper towels around to wipe the saliva from their mouth. If they use the paper towels, they just exchange it. When one gets wet, they put a dry one in, and they manage it that way. But to a lesser degree, these problems can be managed by controlling the intake of very sweet or very sour foods that cause extra secretion. And it may be also helpful to increase or decrease, whatever the case may be, your foods that have higher water content or fluid content. Another step is to see a speech pathologist, and for a couple reasons. They are able to give suggestions to help with techniques to safely swallow and teach family members how to assist with eating and drinking. Also, the muscles for swallowing are the same muscles that we use to speak. So typically, speech will also be affected. The speech pathologist can help with methods of communication. So looking at medications, there are some that can be tried to help decrease the production of saliva. Glycopyrrolate is one medication. It can come in pill and liquid form, can be taken up to 3 times a day. A scopolamine patch, and this is just a patch that you place on your skin, and that can be changed every 3 days. That also helps decrease the production of saliva. And then we have amitriptyline. And amitriptyline works for several different symptoms. It will cause a dry mouth. It also makes you sleepy, so we tend to prescribe that one at nighttime. It's also an antidepressant. It can help with mood elevation. And then some people with bulbar symptoms, they have this involuntary crying and laughing. And so this can also help control those types of symptoms. Atropine drops help with the decrease in the production of saliva, and those drops can be placed under the skin, or under the tongue, every 4 to 6 hours. If these medications are not working well, Botox is another choice, and these are just Botox injections that they place into the salivary glands, something that can be done every 12 weeks, as it will wear off after about 12 weeks or 3 months. So other options, and one necessary thing to have in the home is a suction machine. And that would just allow you to suction all the extra saliva out of your mouth. People also can find portable ones to use if you're on the go, and you can have that. Radiation of the salivary ducts or ligation of the salivary ducts is an option. It's not generally covered by insurance and may not be available in your area. There may not be anybody that can do those. So thick oral secretions can also be a problem. Once these facial muscles become so weak, it causes the mouth to no longer be able to close. And so it can lead to mouth breathing, and mouth breathing causes a dry mouth, which can create thick secretions. But sometimes secretions are just thick anyway without a dry mouth, or they can even be mucousy. So one of the best things that you can do is to hydrate and stay well hydrated. They keep those secretions pretty loosened. And when you think about hydration, you think about the goal should be about 8 cups of non-caffeinated liquid per day, or about 2 liters. And this can be just drank. If you have a peg tube in place, you can put that through the peg tube, because to some people that can seem like a lot of fluid. Or you can do a little bit of peg tube and drinking, however you can get the fluid in you. Liquid nutritions like Ensure and Boost, Jevity, if you happen to be on Jevity through your peg tube, they do not have enough water content to prevent dehydration, so you really need this other water. And it's kind of typical for people with ALS. We hear that they don't want to drink enough because they don't want the inconvenience of having to use the restroom, but it's actually really important to get all that hydration in. Some medications that can be used over-the-counter, guaifenesin, Mucinex, those are the medications we use for chest congestion. They help to loosen secretions. Nebulizers can be prescribed, and they will blow mist into your mouth, and you just kind of inhale it and breathe it in like an asthmatic does. It can be just with saline, Different medications, acetylcysteine or albuterol, can be placed in the nebulizer. Some of our patients, if they use the nebulizer, it's only not throughout the day on a schedule, but just when they feel like they've got a big mucus plug or a blockage there and they really need it loosened up to move it along. Other options are cough assist device and suction machines, which are very helpful. Cough assist is just what it says, and it kind of pushes air and pulls it out, shakes everything up and pulls everything hopefully into your mouth, and then you can just use a suction machine to clear it all out. So if you're not swallowing your saliva, it tends to pull and accumulate in your mouth. When saliva pools in the mouth, you get a plaque or a sticky film that can cover your teeth, build up, and bacteria can grow in these secretions. So if you're having a lot of oral secretions, it's best to use very good daily hygiene, and you really can't ignore it. If that bacteria should happen to be aspirated into your lungs, you could develop a pneumonia. So the oral hygiene is very important. I show here lots of different soft bristled toothbrushes. Fluoride toothpaste is very important. Oral care should be done at least twice a day, once in the morning and once in the evening. There's lots of inexpensive toothbrushes on the market. Here's a couple on this slide. Amazon has tons that you can choose from. People sometimes have a limited range of motion and different ways that they need to hold things. So there's all different types, and occupational therapists can really help with this too. The other thing I'm showing here is Biotene. If brushing is not going very well, or if you just need to kind of freshen up your mouth, the toothettes, and you can just soak those into the Biotene and rub them around your mouth and move them along the tongue and the teeth, and that really helps clear things out and makes your mouth feel fresh. So moving on from oral care, I would like to discuss weight, because weight is very important for ALS patients, and it's especially important to maintain your weight. Energy needs in people with ALS are approximately 15% higher than someone who does not have ALS. So with ALS, having extra weight and body mass is actually really very helpful. Research shows that there is a relationship between weight and longevity. Extra weight increases survival, and loss of body mass is associated with a faster progression of the disease. So we do not recommend or encourage dieting at this time. If you have a low body mass at the time of diagnosis, it's important to try to get some extra weight on. Monitoring your body weight is one of the best ways to keep an eye on your nutritional status as well. So you may experience a minor weight loss just due to the reduction of the muscle mass in your body as the disease progresses. So not eating enough or the right foods will decrease your nutrition and will speed up the breakdown of your muscles, weakening in your extremities and also in your breathing muscles. So nutritionists are a very important part of the care team at this time, because they have many suggestions for maintaining weight. And they are also able to set individual nutritional requirements for oral, or if you have a PEG tube, for PEG tube feedings. And the function of eating can also cause fatigue. The feeling of fatigue can cause you to stop eating before finishing a meal, leaving many nutrients still left on your plate. You may also not feel like you have the energy to eat, and by spending so much energy eating, you may actually end up burning calories, more calories than you're consuming, and lose weight. So you may experience a loss of appetite due to the generalized fatigue or depression. And at these times, it's really important to maintain an adequate caloric intake. So if you lose your appetite or begin to lose your appetite, you want to address the problem early on with your dietitian or nurse or doctor. So if you experience a loss of weight, you can try some of the following. You can eat when you're feeling up and feeling good and in a good mood. Eat smaller, frequent meals. The biggest thing you want to do is to avoid those long periods of time when you're not eating, because it's hard to make up those calories when you do feel like eating again. So eat nutrient-dense foods. Stay away from the light diet foods. You want to eat first and then drink so that your stomach fills up with food at your meal times rather than the fluids. And when you drink at your meal times, think about milk, eggnog, nutritional beverages like Boost, Ensure. Those are all good things. Keep your favorite foods around the house. Just keep mealtime pleasant. You can even eat small meals, small portions on small plates throughout the day. So there's lots of things, to do there that you can make eating seem more appetizing. Because sometimes just eating more food is not an option, and it sometimes isn't easy, especially if you're experiencing fatigue or dysphagia. So you will want to increase the number of calories you in the food that you do eat. So you can do so by eating very high caloric food supplements and high fat, high carbohydrate contented foods. So everything that you've tried to steer away from for the last years, you can now eat, like butters and gravies, olive oils, mayonnaise, cream cheese, sour cream. These all have a high caloric and high fat, high carbohydrate content. So these are all good things to eat. You can sprinkle cheese on everything. You can use dips for your breads and crackers and fruits and vegetables, and those all will add a lot of extra calories. When you drink of milk, think of a higher fat milk like whole milk, using heavy creams. You can even add dried milk powder to regular milk and gravies and sauces to add some extra calories and fat. So when you're thinking about foods to eat, keep in mind foods that also contain high fiber. And the reason for high fiber is to help with constipation, which can be a common issue. If constipation should become a problem, the best solution is hydration. So can't emphasize enough how important hydration is and how important it is to be well hydrated. The best thing you can do also is to add fiber to your diet through fiber-rich foods. And some people will make smoothies and they'll add kale, beans, apples, all kinds of high fiber things into their smoothies, and they can just, suck those up through a straw, which doesn't take a lot of energy. Some people like to do warm drinks. They're also very helpful. There's something on the market, there's a tea called Smooth Move that people say works very, very well to help keep things regulated and moving through. Juices like prune juice especially are very helpful. There's over-the-counter fiber supplements like Metamucil that you can put in a drink or even put it in your smoothie. If those things don't work, there's also stool softeners, Miralax, Docalax, over-the-counters that can also be used. So people, with ALS, fatigue can be a real challenge. We are always giving ways to help preserve energy and manage fatigue. And so there are times when you would like to save your energy for something other than eating, like a family gathering or another fun activity. So this brings me to a peg tube. And a feeding tube is an essential element of care, which helps maintain weight. You can receive your nourishment safely. You can stay hydrated. And it's also another route for medications. So a peg tube. A peg tube is a percutaneous, which means through the skin, endoscopic, which is how they place the peg tube. It's an endoscope, which is a flexible tube with a camera on it that they can view the digestive tract, and a gastrostomy, which is an opening in the stomach. So that's how it got its name. And you will hear the peg tube referred to as a peg, a feeding tube, G-tube, the tube. So it has many different references, but they all mean the same thing. The decision to place the peg tube can be difficult for some people with ALS. They have a difficult time thinking about a tube kind of hanging out of their body. They may think it's a measure of how their disease is progressing. Someone may also feel it means they have to stop eating once they do get a peg tube placed, and they do not. And so never think that you'll have to stop eating if you decide to have a peg tube. So when is a good time to place a peg tube? So the conversation about a peg tube will start early in your diagnosis. And the best time to get a PEG tube placed, it's before it is needed. It is good to have the PEG placed early when respiratory and nutritional statuses are good. So from a respiratory standpoint, one important factor is to have a PEG tube placed before your lung capacity falls below 50% of predicted normal. And so the lung capacity is measured through FVC, which is forced vital capacity. It's a measure of your breathing function. And this is all done through a pulmonology office with a pulmonologist, and they're doing pulmonary function tests that some of you may have already have had done. So to have the PEG tube placed early will decrease the complications related to anesthesia and sedation that will be needed to place the PEG tubes. Other times to consider a PEG tube is if you're spending more than 45 minutes for a meal, and if you're spending most of the day worried about getting in enough calories. So many people and their caregivers are very concerned about getting in enough calories and are closely watching their weight because they know of the importance that weight is. Most, but not all, AS patients decide to get a feeding tube. So once again, getting a feeding tube early doesn't mean you have to stop eating, but what it does allow you is to eat the foods that you enjoy, eat them safely, and eat them in the amounts that you want. And then you can supplement the rest, and then your tube is in place for a time when you could possibly need total nutrition through the tube. If the tube is not placed early, some signs of insufficient nutrition, for example, losing weight and dehydration due to progressing dysphagia, would be another reason your doctor would recommend a PEG tube. So a PEG tube and how it's used. So a feeding tube is just a small tube that goes from the outside of your stomach, or the skin, on the left side of the abdomen, directly into the stomach. It's usually about 6 inches long, the outside tube is, and has 1 to 3 valves on the end to prevent leakage. And usually there's a clamp to compress the tube when it's not in use. The tube can be hidden under your clothes, and the extra tubing is usually just taped to the skin when it's not in use. So feedings, as shown in the pictures here, can be administered by attaching a syringe to the valve and either by using gravity or slowly injecting the liquid supplement through the tube using the syringe. At times, a pump would be needed to slowly administer the feedings, and this would usually be done through the night while asleep. And again, a nutritionist would decide the amount of feedings needed, as well as hydration needs, what we call free water, how often, as each person, again, has different nutritional needs. The nutritionist would look at how much you are still eating and drinking and would just supplement the tube feedings to make you reach your maximum daily intakes. Most medications can be crushed and flushed through the tube as well, and a lot come in liquid form. So some medications, though, just be aware, are not recommended to be crushed. They're considered long-acting or coated. So you always want to contact your physician before crushing or dissolving medications. And as I had mentioned, the PEG tube would normally be placed by a surgeon or GI doctor in day surgery with anesthesia. And what type of anesthesia would be decided by the anesthesiologist and patient. A few days after the placement of your PEG tube, a home health nurse will visit, and they will teach you and your caregivers how to use the PEG tube, as well as supplies will be delivered to your home. So once again, just to reiterate, a PEG tube is not a requirement. It is really a personal choice for the individual, but it does increase chances of a longer and better quality of life. So it's something to consider. So moving on to fasciculations, and by definition, fasciculations are just a spontaneous firing of nerves, cause an involuntary contraction of groups of muscle fibers. So basically, they're a twitch. Many people notice those. You might have an eye twitch or something like that. You might feel your muscle kind of jumping. And these are very common with people with ALS. They're generally not painful, and they usually do not need any treatment. They can be troublesome or maybe even embarrassing depending on what muscle is involved. There really isn't any treatment for fasciculations. You just kind of have to manage those. And as the disease progresses, the nerves will die and they will actually go away. Muscle cramping is another common symptom, spasticity. So muscle cramping is Charlie horses is another name for it. They involve a larger group of muscles, and these can be painful. Many report cramping is worse when the muscle has been overused. So an easy thing to do is try avoiding caffeine and nicotine to see if they potentially can reduce the amount of muscle cramping. Also taking supplements of calcium and magnesium, just in case you might be a little low on those. They help with muscle cramps too. Spasticity refers to muscle tightness and stiffness and increased tone. And spasticity can make movements slow and difficult. The development of spasticity in people with ALS can add significantly to their functional decline and to the reduction of quality of life in the individual. But there are some things that can be done. Treatment for both of these can include gentle stretching exercises. There's muscle relaxers like baclofen and tizanidine that can be helpful. Also, benzodiazepines could be tried. Those are anti-anxieties that tend to make us very calm and will settle things down. You have to be careful with those just because they can cause sedation and dizziness. And a referral to a physical therapist can be very helpful because they can guide your exercises and help you with range of motion. Botox possibly for spasticity, if that's something that you and your doctor agree on. But if you're experiencing any of these and they're becoming troublesome, please reach out to your care team and we'll see how we can help you. I wanted to talk for a minute about suprapubic catheters, and I'm especially speaking to the ladies out there. As you know, we are made very differently than a man. And there are solutions so you do not have to use the bathroom other than not drinking enough fluids. Because as I mentioned earlier, people with ALS tend to not drink enough because they don't want to have to use the bathroom. So if it's getting to a point where maneuvering to bedpans isn't working well, transfers are getting more difficult, and you're just concerned about taxing your caregivers, a suprapubic catheter can be a great option. It may not be for everyone, so it is just an option. The suprapubic catheter is a soft catheter that goes through the skin in the pelvic area straight into the bladder. So a bag can be attached to the end of the tube to collect the urine. The bag gets emptied when it is full, or when you are feeling your bladder is filling, it can be emptied. There is a small risk for urinary tract infections with the suprapubic catheters, but the benefits can outweigh the risk. So if you're feeling like you're getting to this point, this is something you might be interested in talking with your doctor. So I was drawn to this picture kind of as I'm summing things up because it really portrays what happens on a care team or a multidisciplinary approach. And it places the person in the middle with ALS, and really their caregivers could be there as well. And everybody is surrounding them, giving them support. And the arrows are pointing out because that person has all of these resources that they can actually go to. And it keeps you very connected with all aspects of care, ideally through a clinic if you have clinics available to you. And with this, you'll have, being involved in a clinic, you'll have better and easier access to the resources and technologies that can allow people with ALS to live their lives more fully. ALS clinics are a wonderful way to be connected and have continuity in your care along the journey. So I think this is the goal, and I think it is for everyone to have a fulfilling and the best quality of life possible. And that is what we're hoping to achieve with people with ALS too as well. So this is a challenging time for you and your loved ones. So please always reach out to someone on the care team to help you with any questions or concerns. Thank you.
Brenda, thank you for your presentation. I want to, I'm going to want to chat with you for a couple of minutes, so stay with us. But I was reminded by someone within our community the other day that we understand that some folks are using a speak to type feature. We want to make sure we're giving plenty of time for good questions. So I am purposefully providing just a little bit of lag so that folks who do have questions will ask them no matter what means they're doing to put their questions in there. So, question from Roger. Are suprapubic catheters offered to men as well as women to help with frequent urination?
Yeah, men can also have suprapubic catheters. They can be placed the same way as they are with women. So if that's something that you would be considered, talk to your doctor and see if that's something that could be a choice for you. But men can have them as well. It's generally with the women only because of transferring or different dynamics, but men certainly can have suprapubic catheters. Yeah.
Okay, thanks for that. Just a couple of nice comments. Richard says great, and Dustin shares great information. And again, I'm still going to leave a little bit of time so that folks who are wanting to put their questions in, I'm going to allow that to happen. I took some notes, Brenda, that mostly just to kind of reiterate some of your points.
Yeah.
Roger says very informative presentation. But some of the clear messages that I heard from you is people need to, we really encourage folks to communicate their symptoms and not just to a neurologist, share them with the whole team.
Mm-hmm.
Because maybe some of the ways to resolve or even minimize the symptoms can be done through non-prescription, non-therapeutic ways. Last week, I think about Cynthia's presentation and how positioning can help with people's breathing. Mm-hmm. Sometimes it's the hospital bed that helps sleep, or sometimes it's respiratory support. So really it's taking that whole team approach.
Yeah. Yeah. And that's where the support groups are so nice, Laurie, because people really like to tell what is happening with them and how they manage, in hopes that somebody will be able to take their piece of information or their suggestion and use it for them. Yeah. But everybody on the care team, I think, kind of approaches things differently too, and looks at things differently because of their specialties. And so they will always have a different way of looking at a symptom management, with a suggestion.
Yeah. I'll share with everybody that I shared with Brenda this story that someone I work with shared with me. We've heard at support groups how some folks will get, is it a laryngeal spasm? Am I using the right term?
Yep.
And so it can be very scary, and people are feeling like, gosh, is this a breathing thing? Is this, what is it? And again, it may not work for but a handful of folks, but someone said to me, you know how I get through them? And he said, I put my nose up in the air and I hum. And so when he said that, other people's eyes opened up like that. We'll try that. If we have a serious symptom that can be resolved by putting our head up and humming, what's not to try?
Right.
So share your ideas, people.
Uh-huh.
We have a question or comment from Maria. I can't eat anymore. I'm losing weight, 5 isosource a day. What do you suggest?
Yeah. Maria, hopefully you have a nutritionist that is working with you, or that you have available to you, because it might be that you're not taking in enough calories between your isosource and your eating, and a nutritionist is able to determine how much you should have each day as far as caloric intake to maintain your weight. So they look at weight and then caloric intake as well. And that would be a good question for a nutritionist, because they can really determine what would be the best thing for you to do at this point.
And a thought that I have about that, folks who are now 100% using a feeding tube. Again, if you're seeing weight loss, you would want to communicate that, correct? Because
Yes. Yep.
weight loss shouldn't be assumed.
No. Yep. And there's different types of formulas for the feeding tubes as well. So it might be that you might need a different type of formula as well. Yeah, that'd be a good question for the nutritionist.
Great. And I'm not seeing any more comments, but I'm gonna let folks take another minute or two. I also one of the other key takeaways that I wrote down is besides getting suggestions from peers, when you do get suggestions from peers, if it requires a therapy or a treatment or an intervention, be sure to bring them back to your clinic team. Because certainly what works for you may not work for me. And so talk with the team about what you want to try, and just make sure that it's something for you. There are an awful lot of over-the-counter things, and we would never suggest people just randomly try different things. And then I hear a favorite neurologist in the back of my head saying, make sure we let folks, make sure we remind folks to be kind of reasonable about what we hope out of symptom management. That the symptoms, as folks living with ALS know, are very real, and our goal certainly would be to alleviate them, but probably minimizing them or finding ways to manage them is probably the most realistic way to look at things. Any other thoughts, Brenda?
I don't think so.
All right. Well, we can't thank you enough. Maria did respond. Thank you for addressing her comment. We love what you and Sarah do and bring to our clinic team. So thank you both for working together on the presentation. I also want to take another minute to express a special thank you to Kennebec Pharmacy, who sponsored the symptom management presentation today. So thanks to them. And then I just want to take a couple more minutes to do a wrap up for today's symposium, Symposium Part 2. A couple of things to think about for next week. Next week is our last day of the symposium. Again, be sure that you're registered. And if you had any technical glitches today, whether you were participating, whether you were exhibiting, please make sure that you let us know so we can help you get the most out of next week's piece. Many thanks to all of you who continue supporting the individuals living with ALS in our northern New England area. Heron and Smith, again, thank you for being our presenting sponsor and just being such great community partners. And to our speakers, your expertise is why so many show up for this event. Thank you for your work and for taking time from your busy schedules to share your valuable information with us. I am going to take this time to just again thank everybody for being here. Remember that these sessions can be watched again, or you can share them with family. They are recorded and available to you. So thank you all, and have an awesome Friday afternoon and a great weekend.